Well, thank you to the organisers for asking me to come, and thanks to Rajesh for saying some of the nicest things he's ever said to me. So obviously I'm going to talk to you about lung health checks, or by another name, lung cancer screening. This has been something we've been developing in Manchester, I think, probably since about 2015. And obviously it's managed to grab people's attention, so you'll know that a few weeks ago the NHS long-term plan has rolled this out now in one region of each of the cancer alliances. £75 million has been given towards that, and so you'll all, I guess, as UK thoracic surgeons, have the dubious honour of having to try and tackle this. So I'm going to tell you a little bit about how we've done it, perhaps some lessons that we've learned, hopefully, but it is quite a complex business to get right, so let's see where we can get to. So back in the day when we were first developing this is the sort of, I think it's a Wilson and Younger criteria that the screening committee adhere to in terms of whether we should screen for a cancer or not. And our view as a team in Manchester, and I say as a team, that's public health, it's clinical commissioning groups, it's primary care, plus the various disciplines in the cardiothoracic centre, we took this view that for most of these things, lung cancer screening was valid. Okay, so it's important. It's the leading cause of premature death in Manchester. We know a lot about its natural history. We know that we have to introduce smoking cessation. We know that CT is a simple, safe, and acceptable screening test for the population, bearing in mind that CT is increasing by 10% every year in the UK. We know how to evaluate suspected cases. We know we have effective treatments, thanks to you surgeons. We know how to offer that treatment according to NICE guidelines. And of course, back then we had one randomised controlled trial demonstrating a mortality reduction, and of course now we have two. Is the screening programme acceptable to population? Well, never been done. So we didn't know, but we thought we might be able to construct one that was. And we certainly felt that if we ran the programme properly, the benefit of the programme would outweigh the harms. Is it value for money? Again, certainly health economic data based on randomised controlled trials possibly would argue yes, but of course judging health economics off the back of a randomised controlled trial is probably fairly flawed. They're probably the most ineffective use of money in many ways. Certainly don't reflect NHS practice. Agreed plan for monitoring your screening programme. So again, we went to town on this in terms of KPIs and monitoring, and you'll see some of those results. Do we have adequate staffing and resources? Well, this was a pilot for a year, so a baseline and 1 year down the line. So we thought that we locally had enough resource. Of course, it's another question entirely if you're going to roll this out across big conurbations, and then again, appropriate information for participants. So we thought we could put together a programme that would work. So I'm just going to cut to the quick and tell you a little bit about the programme results. So in essence, we took the service to the community. We put our clinic in a supermarket car park so that people did not have to come anywhere near hospital services. They did not have to travel. And you have to bear in mind that these people are hard to reach, they're socially deprived, they have meagre, perhaps, disposable income. The City of Manchester itself has double the incidence of lung cancer compared to the national average, and we were in 3 of the clinical commissioning groups to run the pilot. We used a risk-stratified approach based on PLCO, probably the most validated and calibrated calculator, albeit on a US population, so this was the first time we'd done it in the UK. And if you scored greater than 1.5%, you got immediate access there and then to a CT scan, a low-dose CT scan. We sent out 16,000 invites to 60% ever smokers, and we had capacity to do a health check in about just under 3,000. So it's difficult to formally evaluate an uptake rate because we filled our capacity and stopped counting, but we had about 3,000 unanswered phone calls. And we very much use the principle of a lung health check, or a lung MOT as others have called it in the UK. We know that this is something that engages people more than come for cancer screening. So what was a lung health check? Well, it's specialist nurses assessing symptoms, cancer risk, performing spirometry, consenting them to a research database that we held, and providing very brief stop smoking advice. Now, I should say that as Public Health England were in charge of, or are in charge of smoking cessation services in the UK, the week we went live with this programme, they pretty much withdrew funding for smoking cessation. So it was an interesting, here's the thing we have to have as part of screening programmes, but the national view at the time was to withdraw them, but we've managed to reverse that, thankfully. So this is what we managed to achieve. So 2 rounds of screening. Around about 55% of participants at the health check were eligible for a CT scan. You can see that we had a low rate of positive screens, but a high cancer pickup rate. So NLST was about 1%, UKLS I think was 1.7%. So this I think reflects the risk stratified approach. Very pleasingly, we saw what we wanted to see, that we picked up the vast majority were early stage tumours. And the false positive rate, which again, as you know, is one of the reasons we shouldn't do this, was very low at 2.8%. And again, you see roughly half in the incidence round of these figures, and you'd expect to see this rolled on with annual screening. We looked at some other factors in this as well, and if you have a relevant lung cancer that's going to kill you, the chances are you're going to die of cardiovascular disease. And we know in the programme that 33% of those who participated were at greater than 10% risk of a cardiovascular event over the next 10 years, who were unrecognised by their GP. Okay, so we know we can then offer these people appropriate advice, aspirin, statin, and you only have to treat 30 to save a life. So there's potentially 10 more lives here that we could have saved following that advice. And again, there was also stuff about respiratory disease, so 10% with unrecognised symptomatic airflow limitation. I'm not going to go through the data on that, but that's a cohort that's at risk of pneumonia, exacerbation and death, and again, 10% unrecognised. So these are people we can target the intervention to try and reduce the overdiagnosis bias within the programme. So over the 2 rounds, about 5% of people had a lung cancer detected. We had good adherence between the screening rounds, which I think is in large part due to the community-based location of this. We picked up 1 cancer for every 23 people screened. We did about 40 CTs a day, so that's 1 cancer a day. As I said before, 80% early stage, 90% got curative treatment. I think in the first round it was about 65% surgical resection. Very low false positive rate. We had 1 benign surgical resection for granulomatous disease. And we only had 1 death in the cancer group. So our overall mortality was about just under 2%. And we saw pleasingly this reversal. So the blue bars are the GM Greater Manchester presentation of stage 1, 2, 3, 4 disease, dominantly at 3 and 4, and we managed to flip that round with screening. So very pleasing outcomes. And is it cost effective? Well, so we've reproduced a cost effective analysis, the same that UKLS did, which was a very ultra-conservative cost effectiveness analysis, in that it assumed that I think it took stage 1 disease about 6 years to become stage 4 disease. Now, I think we all know from watching our misses in hospital practice that doesn't happen in 6 years. It happens more or less in 2 or 3. But nonetheless, we followed UKLS because that was a published model. We used NHS costs, so not tariff in some book in Whitehall. This is what we actually charged commissioners for what we did. And of course, the pilot was a very expensive thing. It cost £4,500 a day to have the mobile CT in the community. And our next version is going to be about £2,400. So this is going to be half the cost. But despite that, we got a cost per quality of £10,000, and nowadays it uses £13,000. So this is well within the remit of something we ought to consider at least. And then if you look at the potential impact, of course we can't measure mortality in this, but you could look at the English data for 2017, and you can see CRUK statistics for the distribution of stage and what the 5-year survival is. So you can expect that with people presenting symptomatically, there'll be 3 people alive based on that data over a 5-year period. If you use our data and our stage distribution, with the same 5-year survival figures, which I think is a bit pessimistic because obviously earlier stage disease, smaller tumours, this would be better. But nonetheless, we reckon we can probably have 28 patients alive at 5 years, which means 25 patients per 1,000 screened would be alive at 5 years compared with 3. Right? A sizable improvement in outcome. So what does all that mean? I think if you look back at what was said at the time, this is a sort of traffic light system of things that we thought we knew well. So, we had evidence for a screening test, we had a risk prediction model, we have an age group to target, we had a low-dose CT scan we could use, etc., etc. The thing that we didn't feel we had was how do we engage the hard to reach. The model of care we espouse, and I think has not been made absolutely explicit in the service spec from NHS England, is it was a cardiothoracic centre commissioned service run in very close collaboration with public health, primary care and CCG. And I think that's an important thing to note if you're trying to replicate these findings. We had the CCG had a community engagement team, so they're out there in the betting shops and various other forums trying to make sure that when they get that invitation to come for this health check, that they turn up. It's a GP-based invitation. Again, we know that they're more likely to respond to that than getting an invitation from me. Smoking cessation, as I've said, spirometry, Q risk, all that's the same, co-located. And are very much taking the best of the evidence that's out there to construct a protocol. Okay, this wasn't a trial, it was very much using the evidence to construct a commissioned service. And as I've already said, all referrals came to the regional centre. We obviously have our rapid programme, which is, if you had a positive scan, you came in the following day and we got on with things. We didn't make people wait for a long time, which is obviously psychologically harmful. We know that, and part of the rationale for this is that obviously we know that you do tend to have better outcomes if you're seen in a surgical centre first. And of course, we tend to have all the disciplines you need to run a programme like this at volume and quality. And we have a research programme aligned, which is obviously quite important. So this was the evidence base. We all know that NLST, 20% mortality reduction. We know that if we put smoking in there, it might be as much as 40% mortality reduction. We used PLCO, documents around low-dose CT, and then the nodule guidelines from the BTS, which we just published at this time, which is very handy for me. And then obviously incorporating the new staging manual, particularly around what nodules look like, subsolids, solids, ground glass, and just trying to make sure we use CT, and it is the only screening test that can tell you about indolent biology, make sure we screen out the subsolid nodules and monitor them rather than do anything with them. Did we hit the hard to reach? Well, about 80% were in the lowest quintile for deprivation, so we think so. Okay, so this is IMD data, so it's taken from a whole raft of different measures in the UK, but this is where we want to sit in research trials, of course. This is the median IMD here in UKLS. So we think we hit the people most at risk. They were educated to a lower level in the main, and 20%, 1 in 5 had a family member with lung cancer, and about a quarter had significant asbestos exposure by report. And from analysing the people who came to the second round of screening, they told us very much that the location of that scanner was important in about 3/4. About a quarter said they would be less likely to go to a hospital for that scan. And that was more likely to be the case if you were still smoking or more deprived. So the group you're trying to get most robustly is the sort that's not going to go to hospital. And of course, travel-related issues we know from previous work is a real issue. So when I talk about lung cancer screening and the way we've done it, I very much view it as a harm reduction program. Diagnosing the lung cancers is relatively straightforward, but making sure we don't harm the vast majority of other people who don't have lung cancer is the key thing. So obviously getting those who are most at risk is important, but then overdiagnosis we can manage by a very strict adherence to a robust nodule protocol and by addressing those competing causes. False positives, again, we manage that with high quality radiology, with risk stratification, with the BTS guidelines, and making sure And again, when I've talked about this, sometimes radiologists are not that interested in getting hold of available archival imaging because it's too hard. Well, if you don't do it and you put a CT scanner in the community, I can guarantee you the CQC will turn up and close you down because they tried to do it with us. Okay, so it's important. You can't just go out and scan somebody if they had a scan 2 weeks ago at some other hospital. All right, it's an important part of QA. We have to minimize invasive investigations. So again, that's about adherence to protocol. We've got some very good radiologists who biopsy sub-centimeter lesions, and we're investing in some navigational stuff to make that happen. The radiation side is negligible. It's not a good reason, but you can invest in modern day technology to have ultra low dose, the same dose as a chest x-ray. And I think all of this is really about that model of care, basing it in big centres. As recommended by almost all of the major bodies, you know, this should not be done in district general hospitals. The focus should be centralised, with obviously the screening going out to the community. Lots of operational considerations, which I'm not going to dwell on here. I think I'll maybe just talk about these very quickly because Eric's eyeing me. I think the biggest challenges really are around things like IT and image transfer from these mobile communities. We don't have fixed links into the NHS networks. Capacity planning for surgery, for radiology, for pathology is a real issue. These are really hard-pressed disciplines to recruit to, and they're still giving us some headaches, particularly around theatre staff. Incorporating volumetry routinely is a real challenge for radiologists, but there are some very good softwares out there which we've started to use. And I think it's about partnering actually with key commercial providers. One of the things that we've now got in our latest collaboration is people investing in bespoke units to do this job at scale to a high quality. This allows us to put the ultra low dose scanners out there, and they do bring some added value to the program. They also, of course, in the procurement exercise have to beat each other, which really gets the cost down. That's what it looks like. This has been delivered recently, so this is it. Expandable size, nice and spacious, beautiful. But we've had the opportunity to design this, and our partners have built it and spent quite a lot of money. That's what it looks like. Nice 3 clinic rooms, research rooms. There's smoking cessation counsellors through here. Spirometry and AF screening as well. So it's a big setup, rolling out into all of 30, what is it now? I think it's 36 practices in North Manchester. There are real challenges to do this, but I think one of the key things that's happened for us, I think, is this reorganisation internally. So our senior execs are very engaged. They've created directorates specifically to do this. So we're not having to go through lots of different levels of management across different directorates. So that really helps, and I think that's a good thing to aspire to if you want to run these programs. And otherwise, is that it? Okay. Just a little bit of data on health economics for the whole of Greater Manchester. So we've done a little bit of this, and you can see, based on this data, £3,700 per quality. I mean, that's pretty cheap intervention, isn't it? There's my conclusions. I think the lung health checks are acceptable. We save a lot of lives. It's all about how you do it and who you partner with. For me, I think centralized models work the best, or hybrids, I should say, us working with CCGs, etc. It is hard. There are lots of little things you have to do. Don't just take the easy route, otherwise quality will suffer. And I hope you engage in it and try and deliver it for your cancer alliances. Thank you very much.